Now we're starting chapter 26, renal disorders, and that would include acute glomerulonephritis and nephrotic syndrome, minimum change nephrotic syndrome to be specific. With acute glomerulonephritis, this occurs normally secondary to a strep infection that the child had. Now, many times they will not realize that they had a strep infection. So when the children come in and we ask them, about a history, they may or may not report to us that they had strep throat in the past. But what happens is normally we see this in the 2 to 7 year old age, which is we see a lot of strep throat in, and it's not noted until about 2 weeks after they've actually had the strep throat. So it's diagnosed through basically the history of a strep throat or a history of the child being ill, a sore throat, that sort of thing. And then the actual physical findings associated with this. Because if they've had a strep throat, we can draw anti-streptolysin O titers on the child, which will validate that they have actually had strep throat. And of course, we can always do a throat culture on them, do a swab, a quick strip, and that could come back positive for us to validate it also. We diagnosed it by other physical findings. Specifically, their urinary output will be decreased, a smaller amount, and the urine that they are putting out is described as kind of cloudy, tea-colored urine, or you may hear it called Coca-Cola urine. It's very dark, and that is secondary to the hematuria that they are experiencing. Usually they act very lethargic, they don't feel well, they just don't want to eat very well at all. And if you look at them physically, they tend to have periorbital and facial edema in the morning specifically. It does tend to improve during the day as the child is up and around. And then the most important finding for them would be the hypertension. So when you're doing their vital signs, you will often find that these children are hypertensive, so their blood pressures are quite elevated. And as it says at the bottom, he talks about the anti-streptolysin A titers during the throat swabs and, of course, the urine that would validate the hematuria. Also on the UA, you will find that these children also will have mild to moderate proteinuria as well. So they're also spilling protein as well as the gross hematuria that you see in them. As far as treating glomerulonephritis, our treatment includes monitoring I&Os on these children, very strict I&Os to keep up with how much they're taking in and how much they are voiding out. Because we are very concerned about, of course, the edema, not only peripheral edema, but also cerebral edema. They will also be on antihypertensives and possibly even some diuretics if the edema is severe enough. It's imperative that these children be on daily weights because that is the best way to give us a feel for that child's hydration status and how they're doing and how we're doing in relation to treating this disease. So I-Nos are important, but the best way to determine how well the child's doing in their hydration status is through daily weights. Additionally, we're going to be doing vital signs inclusive of neurochecks every 4 hours. So we will be doing blood pressures, neurochecks, and then just the routine heart rate, respiratory rate, and temps every 4 hours on these children. Additionally, there are also nutritional challenges, shall we say, because they don't feel well, they're very lethargic, they really don't want to eat a whole lot. So we have to strongly encourage them to actually eat good, nutritious foods. We limit them somewhat as far as high sodium foods, things like chips and anything else that would have a high sodium content to it. We don't encourage those in them. So if that's all they want to eat is Cheetos and drink sodas, we try to kind of lead them down a different path and get different foods for them that they would still enjoy. Fluid restrictions may or may not be necessary, and that is entirely dependent upon their output, the amount of edema that they're having, and their blood pressures. But if needed, we may also have to place some of these children on fluid restrictions as well. If we do that, be sure as the nurse that we are informing the family of that, of exactly how much their child can have in an 8-hour period. There's nothing much more depressing than going in at 8 o'clock in the morning for your morning AM assessment and vitals, etc., to realize that this child who is on a 500 cc per shift intake limit has just chug-a-lugged a 12-ounce Coke, and you see it sitting on the bedside table. And when you ask, they say, "Oh yeah, that's what he drank," and you're just wonder going, "Oh dear, there went 360 of my 500 for the day." So usually, if we explain to parents why we are fluid restricting their children in terms they understand, they will be very compliant and very, very helpful to us in that. Next, as far as antibiotics, we will only give those if the child was never diagnosed with strep throat and still currently is positive for that. So if the strep cultures do come back positive, the quick strep, we did the throat cultures and that kind of thing comes back positive, then that is when we would go ahead and treat these children with antibiotics. But if they were treated initially, we no longer need to treat them now because the strep throat has already been addressed. As far as nephrotic syndrome, that's the other aspect of renal disorders that we see in kids. It's caused by an increased permeability of the glomerular membrane. We're not really certain why it happens. We simply know what happens. It may be congenital, primary, or it may be secondary. And 80% of the cases that we see in children is minimal change nephrotic syndrome, which is an example of a primary type of nephrotic syndrome. As far as physical findings associated with that, we will see that the kids gain weight, but it's much more gradual. Parents may report that they notice the clothing getting a little snugger, maybe his little boy's pants seem to be a little tighter around the waist, but they simply attribute it to weight gain and growth in the kids. They don't recognize it as being a symptom of a renal problem. You will notice edema in them, and I will show you a child on the next slide that definitely has all of this. Periorbital edema and facial edema, very noticeable in these kids, and also ankle edema. So you'll notice that their ankles look a little puffy too. They will have frothy urine with decreased volume. Just like with AGN, you had that gross hematuria, very Coca-Cola looking urine. In this case, because they're spilling so much albumin into the urine, it looks very frothy, kind of like egg whites. If you beat them, that's kind of that feel that it has to you. They may have ascites that will be noted in the abdomen. It may look distended, and on x-ray you can confirm the ascites in the children. They are very lethargic and don't feel well, similar to our AGN kids. But we tend to find these kids also tend to be kind of irritable. I mean, they don't feel well. That's the biggest issue. They don't feel well, and they are kind of on the grumpy sort. And if you look at the urine, like I said, and you do a UA on them, they will have gross proteinuria, some mild, maybe hematuria, but the proteinuria is what is most notable for these children. Very, very intense. As far as nursing care for a child with nephrotic syndrome, we're going to make sure they're getting strict INOs done on these children, monitoring their intake and output very, very carefully. Additionally, we support the idea of daily weights on them. I'm sorry, because that, as I said before, is the best indicator of hydration status in children. Thirdly, we're going to be monitoring the edema that we see in them. As this child shows, she's got rather marked facial edema generalized, as well as periorbital edema on her. So looking at the edema, they may also see ankle edema in these children. As far as medications, the first medication we're going to be using is corticosteroids. We will start with a fairly high dose of that, keep the child on it for a while until they begin to be better, improving, and then we begin to wean them off of the corticosteroids, wean them down to hopefully getting a dose that then eventually getting them off. But what happens normally is that the child will get on a low dose and then have a relapse. So with that, when that occurs, you have to bump the dose back up to the large amount that we were to begin with and then start the whole process again. So what normally happens is that these children will be on a fairly significant dose of corticosteroids for a protracted amount of time. They will get weaned down and they go back up, so down and up. And after a while, oftentimes these children will become unresponsive to the corticosteroids. So, in addition to all the side effects of the corticosteroids at their own, then the corticosteroids are not doing what we need them to do, which is reducing the edema and the proteinuria in these children. So, if that occurs, they're no longer responding and the corticosteroids are ineffective. They will be switched over to immunosuppressants such as the one I'm listing you here, which is cyclophosphamides. And of course, there are a number of side effects with those as well. So we want to make sure that we're educating our parents about the medications that their child is on, making sure that they understand all the side effects that go along with and all the bad aspects of it. Also, medication-wise, these children may be placed on diuretics, and if their albumin loss is high enough or significant enough, they may actually have to receive IV infusions of albumin while they're hospitalized. We want to make sure these children are getting the best nutrition possible for them. There are a few restrictions. We don't want them to be taking in a lot of sodium because that simply adds to the edema problem. And we also are not allowing them, to basically free drinks and free water and intake. So, but if they're on a specific fluid limitation, make sure we inform our parents about that, because I find that parents are very compliant as long as they understand why we need their child to be on such a limited amount of fluids. For example, if you only can have 400 cc's per shift, the child can, then we go in and we explain to mom and dad that they can only have, and we show them a volume, maybe on a cup, measured cup in the room, or give them an idea of what a can of soft drink would be. That would be how much, that type of thing. That's 12 ounces, right? So you give them an example of that. So if a child gets 400 cc's, then that would be your example. So, and we don't want them to go over that because we don't want their brain to begin swelling. That's basically the same. It is self